The Neuro scan is a protocol to assess brain function in relation to the posture system and postural design in 3 minutes or less. Hi, I'm Dr. Krista Burns, co-founder of the American Posture Institute, and I know you've seen and heard about the Neuro scan. Let's talk about, from a neurophysiology perspective, what the Neuro scan does and what parts of the brain we're actually analyzing when doing this 3-minute neuro exam in relation to the posture system. So first of all, what we have with the Neuro scan is we're going to do a posture check. Now, when we do a posture check with the Wade technique for postural analysis, well, what part of the brain are we looking at? We're looking at the brainstem, most specifically the pontomedullary reticular formation. Now, the pontomedullary reticular formation is going to be between the pons and the medulla, where the pons and the medulla come together. Now, the PMRF is like we call it the powerhouse of your posture. The function of the PMRF is to inhibit flexion. So if you see when the patient does the Wade technique for posture analysis and you check their posture, if you see that they have flexor dominant posture, that's going to give you indication that there's dysfunction of the PMRF within the brainstem. Okay, so the first part of the neuroscan then is for PMRF function, which lives within the brainstem, the pons, and the medulla. And then the next thing is the patient sticks out their tongue. So why would the patient stick out their tongue on this posture examination? Well, as the patient sticks out their tongue, we're looking for any abnormalities, such as a lateral deviation of the tongue. Cranial nerve 12, which also lives within the brainstem, right here in the medulla, controls tongue movements. So as the patient sticks out their tongue, what we're really looking for is how is cranial nerve 12 functioning. That's going to give us insight of how the medulla within the brainstem is functioning. Okay, so the first part we did PMRF, which is pontomedullary reticular formation, and then we did cranial nerve 12, which is the medulla of the brainstem. And then the patient stands on one leg. So when the patient stands on one leg, we're looking to see which side they have initial postural sway. The side of initial postural sway is going to be the lateralization of vestibular dysfunction. Now, the vestibular system has 4 nuclei. The 4 nuclei of the vestibular system live within the brainstem, within the pons and the medulla. So when we're checking vestibular function, we're actually also checking function of the pons. So that's where the relation is there. So again, the patient stands on one leg and we're checking the vestibular system. Again, the vestibular nerve nuclei live within the PMRF, more specifically within the pons. So again, we check PMRF with the posture check. We check cranial nerve 12, which is part of the medulla, with the sticking out the tongue. Then with the vestibular system, one leg balance, we're checking for initial postural sway for side of lateralization and dysfunction. Then we're going to be looking at the vestibular system, which is going to be the pons for the vestibular nuclei. And then after that, we're checking midline cerebellum. So when the patient does a Romberg's test, we're again looking for the initial side of postural sway. Now that's going to check midline cerebellum. So within the cerebellum, which is also referred to as a little brain, within the cerebellum, we have the vermis, which is the midline, we have the intermediate, and we have the lateral aspects of the cerebellum. So when you're checking with Romberg's test, you're actually checking the midline cerebellar aspect, which is really important for postural neurology because the vermis is very well integrated with upright postural design of the spine itself. Okay, so when we do that midline cerebellum test, that's going to be Romberg's position. And they're going to lean or lateralize towards the side of dysfunction. And then after that, we're going to do rapid alternating pronation and supination, or rapid alternating movements. So the patient is going to hold their hands like this. Now, when they do that, we're looking to see which side does not move as fast. There's less coordination. So that's going to indicate which side of the lateral cerebellum has dysfunction. So we're utilizing our hands, which means we're activating and analyzing the lateral cerebellum. So again, if we look at the cerebellum here, then we have the vermis, which we're testing with the midline, which is going to be the Romberg's, and then the lateral aspect of the cerebellum is what we're testing with the rapid alternating pronation supination, the RAPS movement, which looks just like this. So now at this this point, again, we checked the PMRF with the posture check. We checked cranial nerve 12 or the medulla sticking out the tongue. We checked the vestibular system with one leg balance, also the pons. We checked midline cerebellum with Romberg's. We checked lateral cerebellum with rapid alternating pronation supination, which then brings me to the midbrain or the mesencephalon. So over here with our brainstem, we have the midbrain or the mesencephalon, we have the pons and the medulla. So the most superior aspect of the brainstem is going to be the mesencephalon, which is also called the midbrain. So when we're checking the midbrain, we're checking convergence of the eyes. Why? What's the connection there? So we have cranial nerve nuclei that control the extraocular muscles of the eyes that live within the midbrain. So when I check convergence, I'm checking the ability of the extraocular muscles to converge. I'm checking the movement of these muscles. Now those are controlled by cranial nerve nuclei that live within the mesencephalon and the midbrain. So as I'm checking convergence, I'm actually checking midbrain function. Then we have the patient, we're going to check the visual system by doing eye circles. Now the reason we do an eye circle is because with one circle, we can hit all fields of gaze to check function, again, of the extraocular muscles. So when we're doing that, we're checking the visual system. So by checking the visual system, we're looking at their gaze, their smooth pursuits, and their gaze stabilization. Okay, so again, let's review this. PMRF, posture check. Cranial nerve 12, medulla, sticking the tongue out. Vestibular system with one leg balance, also the pons. The midline cerebellum, Romberg's position. Lateral cerebellum, rapid alternating pronation supination. Midbrain with convergence test. Visual system with gaze stabilization and smooth pursuits. Now let's talk about the motor cortex. The motor cortex is located within the frontal lobe. It controls all voluntary movement and stabilization throughout the body. So the frontal lobe, motor cortex. We test the motor cortex by testing the muscle tests. So if I do a muscle test of the right arm, that's my left motor cortex. If I test my left arm, it's my right motor cortex. That's a contralateral system with those muscle tests. So when I do a muscle test of the deltoid, I'm actually testing the motor cortex on the opposite side. And then we want to check the sensory cortex as well. So the sensory cortex is located within the parietal lobe up here, and that's going to be about this part of your brain. So frontal lobe, motor cortex, parietal lobe, sensory cortex. Now, in order to do that, we're going to do what's called the spinal push test. Now, the spinal push test is going to send sensory information to the sensory cortex for sensory motor integration. When there's a breakdown in sensory motor integration, we see anterior postural sway. So that breakdown in sensory motor integration is really valuable to us because it tells us where to apply our treatment protocol. But in addition to that, let's understand the neurophysiology. So the sensory cortex, we have light touch because we're lightly doing a touch of the spinal push test, and also joint position. So if I push on the spine and I change position of my joints, that joint position sense is going to be sent to the sensory lobe, or the sensory cortex within the parietal lobe. So that's what we're testing when testing with the spinal push test. Wow, can you believe that we collected all of that information from the neuro scan? Literally, within 3 minutes or less, we're able to understand the function of the brain in relation to the posture system. And when we have that understanding, we can make very specific treatment protocols for our patients every single time they come in the office. So before we go, let's do one last review of the neuro scan and how we're evaluating the brain. So again, the first part is a check of the posture. That's the PMRF, the pontomedullary reticular formation. If you see flexor dominance, there's dysfunction of the PMRF within the brainstem. And then we check cranial nerve 12, sticking out the tongue. It's going to deviate towards the side of dysfunction. Medulla in the brainstem. Vestibular system, one leg balance. They fall or lateralize to the side of dysfunction. Vestibular system, pons in the brainstem. Midline cerebellum, the vermis within the cerebellum is going to be your Romberg's test. Lateral cerebellum, rapid alternating pronation or supination of the hands. And then the midbrain, The most superior part of the brainstem, the midbrain right here, convergence test. Visual system, gaze, smooth pursuits and gaze stabilization. Motor cortex, muscle test. Remember, that's a contralateral system. Sensory cortex, also a contralateral system, through the spinal push test. So literally, when we're performing the neuroscan, we have collected so much valuable information of the neurology controlling your patient's posture system so that you can make very specific treatment protocols every single time they come in the office. And the best part, you can do the neuroscan post-treatment to ensure that the treatment that you selected was the best option for that patient that day to build neuroplasticity of the posture system and overcome postural collapse to stimulate upright postural design.